Rajasthan chapter. And today, Dr. Kalpana Chandwani, final resident from Mahatma Gandhi Medical College and Hospital in Department of Family Medicine, will be presenting an interesting case on a 20-year-old male patient presented to us with weight loss and tachycardia. I would like to thank and welcome Dr. Hemant Saluja, sir, for accepting our invitation as a moderator. Thank you so much, sir.
Thank you very much. Indeed, it's always been a pleasure to be associated with the Spice Route.
Thank you, sir.
And Rajasthan MGMS has always been a very, very gracious host. And it's
Thank you, sir.
educational feast always.
Is it visible?
Yeah, wonderful. Great. Please go ahead.
Okay. Welcome, please. Good morning. I, Dr. Kalpana Chandwani. Is my audio audible?
Yes, you're loud and clear.
Okay, sir. Good morning. I, Dr. Kalpana Chandwani, family medicine resident, third year from Mahatma Gandhi Medical College in Jaipur, would be presenting a case under the guidance of Dr. Hemant sir and Dr. Shalini Garg ma'am. Just a minute. Patient X, 20-year-old male, resident of Tong, a second-year BA student, came to the family medicine OPD on 7th August 2024. He presented with the chief complaints of weight loss for 6 months, palpitations for 2 months, easy fatigability and generalized weakness for 2 months, and shortness of breath for 1 month. History of presenting illness: the patient was apparently asymptomatic 6 months back, after which he developed weight loss, which was gradual in onset. Patient started noticing that his clothes were getting loose. About 10 to 8 kgs weight loss was in 3 to 4 months, which was unintentional, in spite of an increase of appetite, and there was no change in bowel habits. The patient also complained of palpitations, which were insidious in onset, gradually progressive, present since the last 2 months, and present of the day. It aggravated on doing exertional activities, and there were no relieving factors. It was not associated with chest pain, dizziness, nausea, and vomiting. He complained of easy fatigability and generalized weakness since 2 months, which was gradual in onset and affecting daily routine household activities. He complained of shortness of breath for 1 month, which was insidious in onset, gradually progressive, progressed from NYHA grade 1 to NYHA grade 2. There was no postural or diurnal variation, no orthopnea or PND, not associated with cough, expectoration, or wheeze. The patient had no complaints of chest pain, syncope, or dizziness, no lower limb swelling or swelling anywhere in the body, no fever, chronic cough, or abdominal pain, no sweating, hand tremors, no increase in frequency of urination, nocturia, and no heat or cold intolerance. There was no fear or stress. The patient has no previous comorbidities. He has no history of any surgery in past. There is no history of TB or TB contact. There is no significant treatment history. Personal history: the patient is vegetarian by diet. He has an increased appetite and disturbed sleep. The bowel and bladder habits are regular. There is a history of smoking since 4 years, daily 10 cigarettes per day, which accounts to 2 packs a year, and occasional alcohol consumption for 2 to 3 years. The patient born out of non-consanguineous marriage. There is no family history of any chronic medical conditions. The socioeconomic history is as shown. The patient resides in a Pakka house with 7 family members. He lives with his parents in a well-ventilated house with indoor sanitation. There is a clean pipe potable water supply. There are no pets. According to the modified Kuppuswamy scale, he accounts for upper lower class. The summary of the case is a 20-year-old male, chronic smoker with significant weight loss, increased appetite, palpitations and dyspnea, and generalized weakness. What are the differentials of such case? The differential can be broadly classified into infectious and non-infectious causes, the infections being bacterial, tuberculosis, viral HIV/AIDS, fungal, histoplasmosis. In non-infectious causes, it can be divided into the endocrine causes, which includes hyperthyroidism, diabetes mellitus, type 1, and pheochromocytoma. The cardiovascular includes valvular heart disease, and the miscellaneous includes anemia, drugs, and malignancy, like leukemia. In the general physical examination, proper consent was obtained and patient was examined in sitting position. The patient is thin built and poorly nourished, conscious, restless, and alert. He is well oriented to time, place, and person. He has a height of 162 centimeter, weight 40 kg, which accounts for a BMI 15.2 kg per meter square. He is tachycardia of pulse 140 beats per minute, regular rhythm, normal volume and character, with no radial or radiofemoral delay, or peripheral pulses felt with no vessel wall thickening. The JVP is not elevated and carotid pulsation is hyperdynamic. The patient has a respiratory rate of 22 cycles per minute, which is abdominothoracic pattern. 130 by 90 mmHg BP measured in both arms in sitting position. The patient is afebrile and there is no pallor, cyanosis, icterus, clubbing, edema, and lymphadenopathy. There is neck swelling present, which will be examined, and spine is normal. Since there was a midline neck swelling, so the patient was subjected to a thyroid examination. On inspection, the patient was examined in sitting position with neck slightly flexed. There was a globular, diffuse midline swelling with smooth surface moving with deglutination. It was approximately 4 into 3 centimeter, extending from sternocleidomastoid muscle on both the sides 2 centimeter above the supraesternal notch. The skin over the swelling is normal. It is a non-pulsatile swelling and on-tongue protrusion test is negative. On palpation, the inspection findings were confirmed. There is no local rise of temperature. There is smooth surface and a firm consistency of the swelling. It is non-tender and the swelling is mobile over the underlying structure. The skin over the swelling is normal and no thrill is present. No bruit on auscultation. The patient had lid leg and lid traction present on eye examination and there is no exophthalmos. On cardiovascular examination, on inspection, the chest shape is bilaterally symmetrical. An apex beat which is diffuse seen in 4th and 5th intercostal space in mid-clavicular line. There are no scars or distended vein seen. The spine is normal. On palpation, inspection findings were confirmed. Hyperdynamic apex beat palpated at the left 4th and 5th intercostal space, 1 centimeter lateral to the mid-clavicular line. No thrills or rub or paraesternal heave palpated. No pericardial bulge or epigastric pulsation palpated. On auscultation, there is a loud S1 heard in aortic and pulmonary area, loud S2 heard in mitral area, no murmurs heard, no addition heart sounds heard. The other systemic examinations were normal. The summary of this case, 20-year-old male, chronic smoker, presented with significant weight loss, palpitations, shortness of breath. He is thin built, poorly nourished, and underweight with a BMI of 15.2 kg per meter square, with severe tachycardia of 140 per minute, tachypnea, palpable, smooth, diffuse, globular, non-tender swelling of thyroid of approximately 4 into 3 centimeter. He has lid leg and lid retraction on eye examination, and there is loud S1 and S2 present. Probable diagnosis is primary thyrotoxicosis, most commonly Graves' disease. The investigations which were followed were the CBC was the complete blood count of the patient was normal. The ESR was normal. He has a low serum TSH and serum FT3, free T3 and serum free 334 was raised. The FBS, SGPT, SGOT, serum creatinine, HIV 1 and 2 were in normal limits. A scintigraphy scan was done, which showed technetium thyroid uptake of total 10.2. In the right lobe, it was 4.9, and in the left lobe, it was 5.3, which was suggestive of hyperfunctioning thyroid gland, diffuse toxic goiter of Graves' disease. The ECG is suggestive of sinus tachycardia. 2D echo shows no RWMA and LVEF of 60%. The final diagnosis was made of primary hyperthyroidism, Graves' disease in impending storm. The Borch-Schwarzkopf score come out to be 35, which is suggestive of an impending storm. Patient was started on tablet carbimazole 20 mg BD, tablet propranolol 40 mg BD, and lubricant eye drops. Patient was counseled about his disease and need for regular follow-up and compliance. The patient also undergone smoking de-addiction and he was started on nicotine gum replacement therapy, 2 mg nicotine gum SOS. The 5 major steps for intervention in smoking de-addiction were followed, which include ask, advise, assist, and arrange. Other drugs which can be prescribed in de-addiction are bupropion and varenicline. The patient was reviewed after 7 days. His compliance was good and he was symptomatically better. His pulse rate came down to 100 per minute and BP was 120 by 70 mmHg. He was counseled for smoking de-addiction, continued on the same treatment. Next follow-up was planned after 6 weeks with serum TSH and free T4. Approach to hyperthyroidism. This chart depicts an approach to hyperthyroidism. When a patient with the symptoms present, we have to take up the TSH and unbound T4. If the TSH is low and unbound T4 is high, it indicates a primary thyrotoxicosis. And if the patient has features of Graves' disease, it is said as Graves' disease. And if the features of Graves' disease are absent, like globular swelling, then it is then a query of multinodular goiter or toxic adenoma is given. If this is also not the possibility, then a radionuclide uptake scan is done, and low radionuclide uptake indicates a destructive thyroiditis, iodine excess or excess thyroid storm. And this rules out the other causes, including stimulation by chronic gonadotrophin. If the TSH is low and unbound T4 is normal, then a measurement of unbound T3 is done. If it is high, it showed T3 toxicosis. If it is normal, it is a case of subclinical hyperthyroidism, and a follow-up in 6 to 12 weeks is done. If the TSH is normal or increased and high unbound T4, the TSH secreting pituitary adenoma or thyroid hormone resistant syndrome is kept in diagnosis. If the TSH and unbound T4 is normal, no further tests are done. The pharmacological management covers the first-line agent, which includes the beta blockers, atenolol, propranolol, and anti-thyroid medications, methimazole, which is a dose of 5 to 120 milligram orally per day, and propylthiouracil and radioactive iodine, with their different benefits and side effects, which prompts the usage in various conditions. The other agents which can be used are cholestyramine and glucocorticoids, which are most commonly used in thyroid storm, NSAIDs, and supersaturated potassium iodide. The benefit and risk of various therapies. In anti-thyroid medication, in pregnancy, propylthiouracil is safe for the fetus in the first trimester. After the first trimester, in the second and third trimester, methimazole therapy or carbimazole therapy can be given. The methimazole causes agranulocytosis, hepatotoxicity, which is more common with propylthiouracil and rash. Radioactive iodine have the risk of aggravation of Graves' orbitopathy, especially in the smokers. Hence, it is contraindicated. And it is also contraindicated in pregnancy. Thyroidectomy is beneficial for the patient who have no risk exposure to adverse effect of antithyroid medication or to radiation, and it has little chances of Graves' disease recurrence. Indications of surgery are toxic adenoma solitary nodule, retroesternal goiter, thyroid mass causing compression symptoms, failure of medical management, chronic smoker with Graves' disease, and ophthalmopathy not responding to antithyroid drugs. The management of a thyroid storm is done under 5 categories, which include supportive treatment, airway maintenance, oxygen, and IV fluids are given. The drugs which inhibit the T3 and T4 synthesis, that is methimazole orally, rectally, or through nasogastric tube IV 20 to 40 mg every 8 hours, propylthiouracil orally, rectally, or through nasogastric tube 200 to 300 every 8 hours. Inhibition of T4 and T3 release is done by giving solution of potassium iodide 5 drops orally every 6 hours to be started at least 1 hour after administration of an antithyroid agent. Heart rate control is done by giving esmolol or metoprolol, esmolol IV in the dose of 50 to 100 microgram per kg per minute, propranolol 60 to 80 milligram orally every 4 hours, metoprolol IV 5 to 10 mg every 2 to 4 hours. If the beta blockade is contraindicated, diltiazem can be given. Inhibit T4 to T3 conversion is done by giving hydrocortisone 100 mg IV every 8 hours. Treat, and most importantly, treat the precipitating cause. Thank you.
Thank you, Dr. Kalpana. It was indeed a remarkable performance.
Thank you, sir.
It seems that you have really worked hard on this. And I was wondering, can we move back to the slide of differentials?
Yes, sir. Yes, sir.
Yes. Okay. Now, for the sake of those who joined late and for the benefit of all those who might have had some technical problems listening to the audio or some other things because of network connectivity, it was a case of unintended weight loss. Am I right? In a
Yes, sir.
20-year-old male with
Yes, sir.
midline neck swelling, palpitation,
Yes, sir.
and
And
anxiety,
shortness of breath, sir.
and along
Yes,
with
sir.
palpitations. Yes.
Yes, sir.
So, as the slide is very, very elaborate and complete, almost complete, I would like to ask Dr. Kalpana that did the thought of it being a parasitic infection of the intestines ever cross your mind? Can this picture occur in a helminthiasis?
Sir, actually, in the infectious causes, the palpitations which were present in the patient, it actually, I actually thought of the DD of being a cardiovascular to the side of cardiovascular or a respiratory cause,
Very
which
rightfully,
can cause
it is a major DD, but
major.
can hookworm infection cause anemia, and then can
Yes, a
it lead
weight
to?
loss.
But we
Yes,
don't see that
anemia.
here. We don't see that here as
Yes, sir. Yes, sir.
so
It can be.
probably that can be included.
Yes, sir.
Second, otherwise, almost everything. It's a very relevant slide. HIV, AIDS, and tuberculosis are being the most commonest cause of unintended weight loss, and amongst the infections and
Yes, sir.
miscellaneous malignancy, they can all be classified as. So, what is that condition called when you lose more than 5% of body weight? What is that typical
Unintentional
condition? Yeah. So, what is it
unintentional
clinically
weight loss.
called? Yeah. What is it
Unintentional weight
called?
loss.
Have you heard the way?
Anasarca. Any anasarca.
No, the opposite of
Unintentional.
anasarca. What is the opposite of anasarca? It is called cachexia.
Cachexia, yes, sir. Cachexia.
So when does cachexia occur?
Sir,
What all conditions can it occur?
sir, in unintentional weight loss.
I'm sure you know it. You know it. Just
Yes, sir.
relax and gather your thoughts.
Yes, sir. Yes, sir. Sir, if we divide it systematically in endocrine causes, if the patient had diabetes mellitus, if he has pheochromocytoma, diabetes insipidus, in infection causes, it can be tuberculosis, HIV/AIDS, histoplasmosis.
Okay, so you can see it commonly in cardiac failure. You can see it in compromised, immunocompromised conditions. You can see in tuberculosis, untreated tuberculosis, miliary tuberculosis. So how do you distinguish, what efforts in your clinical examination did you do to rule out cachexia?
In the clinical examination.
Or in the investigations? What could you have done more to, if I were to tell you that, well, why can't it be cachexia? He's lost more than 5% of his body weight.
Yes, sir.
So why can't it be called cachexia?
So the weight and height of the patient was taken.
I am sure. Yeah, you told me the BMI. Yes, you told everybody the BMI.
More which
See, you've done everything. Let me not tell you that you have missed out on anything. No. I'm just giving you adding another dimension to your thoughts, so that not just passing the exam, you will get a gold medal.
Yes, sir. Sir, I was thinking that we could have calculated the protein energy intake, the calorie intake of the patient.
See, in LF, you're very right. You could have taken that, but that is a cumbersome history, right? For a 20-year-old.
Yes.
Had it been an under 5 or something, that could have been easily forthcoming and more relevant.
Yes.
So what investigation can you do in cachexia? Simple. You can do an albumin.
Yes, sir.
Serum albumin to see if there is a chronic ketogenesis or chronic negative catabolic state.
Yes, sir.
Right.
Yes,
and you can check the muscle mass with a clinical measuring tape. So you can add, if I were to tell you, no, this could be, why do you say it is Graves' disease? Why can't it be Hashimoto's thyroiditis which is called Hashitoxicosis? Why can't it be Hashitoxicosis?
Sir, the symptoms which he presented with are not of more points towards hyperthyroidism.
Yeah. So what is Hashimoto's thyroiditis?
Sir, it is the case of patient with autoimmune cause of hypothyroidism.
Yeah, but suppose in the initial stages, what happens? You're so right that Hashimoto's thyroiditis is a case of autoimmune hypothyroidism, because when the thyroid substance gets destroyed, it releases the stored form of T3, T4. Now, when it is releasing the stored form of T3, T4 in its process of destruction, it mimics thyrotoxicosis, and that state is called Hashitoxicosis.
Yes.
It is a transient phase which may last from, say, a couple of weeks to maybe 6 weeks.
Yes.
So you got to follow that up. That could be one of the differentials that you could consider.
Okay.
You've done a brilliant job. Really brilliant job. You've talked about how to cure, how to treat, manage thyroid storm. You've got a wonderful spectrum of the whole thing you've covered so well. But I'm just suggesting you that if you think proper, you could actually add this also to the repertoire of differentials.
Yes.
And how do you distinguish between the two, Hashitoxicosis and Graves' disease? One is hypothyroidism, one is hyperthyroidism, both in transient state of hyperthyroidism. So how are you going to distinguish?
Sir, a patient with Graves presents with a swelling. There is presence of a swelling, not.
See, goiter can
on the
happen in both.
both. Yes, sir.
So anti-TPO and
And they can be
these will,
also present.
yeah, they will rise in which one?
Sir, anti-TPO, sir, rises in both. It in
Okay,
the hush.
so this is your homework now. Okay. How do you distinguish between Hashimotoxicosis and Graves' disease?
Okay,
Okay.
okay.
Dr. Shalini, would
Sure.
you like to add something?
So I think so you have asked among like all questions among the differentials. I just want to ask few more questions to Dr. Kalpana. Kalpana, as sir rightly said, the difference between the Hashimoto and Graves. I think you can read about it if you don't know that as of now. Anything else you can think about in this case?
Regarding
See, so your patient presented, you know what is go to the this previous slide once, no? Before this. So, 20-year-old male. Yeah. So, anything else you want to comment on the differentials?
ma'am, drug addiction, but this patient didn't have any. Weight loss.
Okay, just tell me 5 causes of unintentional weight loss.
Ma'am, tuberculosis, congestive cardiac failure, uh, ma'am, infectious diseases like parasitic infection, HIV/AIDS.
These are already discussed. Anything else you want to focus on?
Ma'am, pheochromocytoma.
Okay, when you have listed pheochromocytoma, and if I say that it may or may not be, what is the presentation in a patient with a pheochromocytoma? Is your patient like? Did you look at those things?
No, ma'am, not like.
So why, if you are saying it is pheochromocytoma, what are the positive and the other things you have not found out?
Ma'am, the BP of the patient is not higher. Like the range of the patient is 130/90. In pheochromocytoma, it presents with around 180 to 120, 200 on the higher side.
Okay.
So what in history could you have asked about to be more specific to pheochromocytoma? Is there any particular question that you think you should have or you could have asked?
Sir,
I think that is what
the
Dr. Shalini is
tachycardia.
asking. See, have you you could have asked about flushing.
Flushing, yes.
Correct.
Okay, sir.
Kalpana.
Yes, ma'am.
Okay, let's move on to the other slides. Just forward now, just forward the slides one by one.
Yes, ma'am.
Okay, just go to the eye examination. Okay, what do you mean by lid lag or and lid retraction in Graves' ophthalmopathy? How do we see?
Ma'am, lid lag is basically if we ask the patient to look downwards, then there is no proper closure, and lid retraction is the sclera the bulbar conjunctiva is visible. In normal patient, the conjunctiva above the cornea is not visible.
Okay. And in your patient, both were there, lid retraction and lag were there.
Yes, ma'am.
Okay, I just want to ask you if since you told the patient was a smoker.
Yes, ma'am.
Right? And your patient had Graves' ophthalmopathy, maybe the initial presentation, right?
Yes, ma'am.
Okay, so what is the definitive mode of treatment if the patient don't respond to antithyroid medications?
Ma'am, in such a case, the definitive move will be thyroidectomy because a patient who is smoker In that patient, radioactive iodine aggravates the orbitopathy.
Okay.
So thyroidectomy will be preferred.
Okay. Can you give me, just tell me how you have come to diagnosis of thyroid directly when your patient is having a swelling over the neck? So my question is, what are the differential diagnosis of a neck swelling?
Ma'am, the swelling can be midline, lateral swelling. So, ma'am, in midline, it can be a thyroglossal cyst, and lateral, ma'am, lymph nodes, cervical lymph nodes
What else?
can be a DD of swelling in this age group.
Anything else?
Thyroglossal cyst, and lymphadenopathy.
See, you divide it into midline, okay, and then the lateral swellings, right? So
Yes,
what are
ma'am.
the midline swellings?
Ma'am, thyroid, thyroglossal cyst,
Hmm.
carcinoma thyroid,
That's
except thyroid, extra thyroid. Ma'am, lymph node swelling, lymphadenopathy.
What about the subhyoid bursitis or mental lymphadenopathy?
Yes, ma'am.
Anything else in the
Subhyoid.
peripheral? Anything else in the lateral swelling?
Ma'am, in this age group, lymph node, lymphadenopathy, I could think of.
Okay. So if you want to ask anything,
Yeah. So what was the respiration you said about the this gentleman, 20-year-old lad?
Say tachypneic,
No, no. What was
abdominal
the type of
thoracic.
what was so? What is the normal type of respiration in a male?
Sir, in a male, it is abdominothoracic.
Are you sure?
Yes, sir. Female, it is thoraco-abdominal.
Are you absolutely sure? Or is it the other way around?
Sir, I am sure.
Okay, just check it out. Okay, and secondly, so you mentioned about the whole spectrum of treatment of thyroid storm,
Yes, sir.
and you mentioned about everything else, including propranolol, including detox. So, if you think it could be cardiac failure, why could it not be cardiac failure? So, did you check for liver tenderness?
Yes, sir. I checked for liver tenderness. There was no pedal edema present. There was no JVP raised.
Okay, good. And so, why can't it be thyrotoxicosis in failure?
Sir, the grading which was taken out, it was coming out to be impending failure, which
No, that
includes
was
other
thyroid storm. That was thyroid storm,
thyroid.
impending thyroid storm.
Yes, sir.
So
Thyrotoxicosis.
why can't it be in thyrotoxicosis? See, how we describe the diagnosis is Graves' disease, thyrotoxicosis, not in failure, in failure. That's how it's classically, conventionally described. Because thyrotoxicosis is one of the causes of cardiac failure. Untreated thyrotoxicosis is one of the causes, long-standing. See, a pulse rate of 140 is tremendously high,
Yes, sir.
and it can tip the person to cardiac failure, right?
Yes, sir.
So, weight loss, you have weight loss, you have tachycardia, you have palpitation, you have what else was there? You have NYHA class
Okay.
2,
Yes.
shortness of breath. So, but without edema. So the points in favor of cardiac failure are all these, and the points against them are there's no edema.
Edema.
So that's why. So you should have a support to answer that. Yes, I did not say not in failure, because There was no edema. There is
Yes,
no orthopnea. There is no
PND, PND.
yeah. So you are absolutely well prepared, but you are probably in some more presentations will give you more confidence, and you are absolutely there. Sometimes you know what the you will be asked simple questions like the ones I asked, whether it is thoracoabdominal or, but you are right, it is abdominothoracic, but you have to be absolutely confident.
Yes,
Is that okay?
yes.
Okay, wonderful. That was educational. I think so. Let's sum it up. So it was a case of unintended weight loss with midline swelling, DDs being, yes, Dr. Kalpana, DDs being,
Yes, sir. So DDs being tuberculosis, the malignancy, HIV, AIDS, and parasitic infection, histoplasmosis, and pheochromocytoma, anemia, and
so
Graves' disease.
so
Thyroid.
if it was impending thyrotoxic storm, uh, was it not proper to seek the inputs of an thyroid endocrinologist?
Yes, sir. Yes, sir. I'm sorry, I missed it. We also seek the input of endocrinologist.
Because we as family medicine people must work to the hilt of our capacities, but
Yes,
within the limits of our expertise, you know. So sometimes it is to safeguard oneself from legal jeopardy that you have to, because a family physician is an office practice.
yes,
It's not in the hospital, never. It's always in the community. So in the community, you identify a condition, treat it, and you have to timely send it to the concerned subject matter expert if you think it is impending worsening.
yes.
Okay, so I think you did a great job. Dr. Shalini, would you like to add anything else?
Yes, sir. Kalpana, so as
Yes,
I
sir.
just want to highlight here that yes, endocrinologist opinion was taken for this case as the patient heart rate was really 140 to 150 in between, and yeah, so that treatment was actually given by endocrinologist, and we were in also in that loop. Patient reported to us with the treatment, and why a family physician is important. I would like to highlight here that even patient who had gone to endocrinologist and came back to us, and he wanted advice whether ma'am or sir should I go for a technetium scan. So the trust the what a family medicine doctor is having on with the patient is actually remarkable. It's just that we need to do a proper counseling. So our patient was very worried when he came to us. He didn't even was able to sit on the stool. He was like, I'm like losing weight like anything, and his
Mm.
heart was pounding out actually. So initially we were also not thinking in as like till we examined the neck, we were not sure whether it is actually a thyroid case. We were thinking in the cardiorespiratory weightage we were giving more, but as soon as we examined the thyroid and it had a palpable swelling, so that's how we came to the diagnosis for this case.
Yeah, so a very
And
valid point by Dr. Shalini that see, you are a family physician is not just the healthcare provider, it is also a resource person for a decision maker, a validator for the person who seeks your professional opinion, because you know more and more about more and more rather than knowing more and more about less and less. The subject matter specialist or expert knows more and more about less and less, but the family physician is supposed to be knowing more and more about more and more. So you not only endorse and help the patient take an informed decision, you also do professional gatekeeping. That yes, I don't think you need to go to the neurologist. I think you need to go to the endocrinologist.
actually, that's true, sir. Because most of the patients they are very confused. They are not able to decide. They go to multiple doctors, and then they come to us because family medicine is I would not say it is a budding field, but still people are not aware much of it. So when they come to us, they don't leave us then later. They're like, ma'am, we are like, yes, we are going to come to, we will be coming to family medicine OPD first. And they bring their relatives to us that, okay, fine, ma'am, please advise us what we have to do. That advice thing is something that's, it's in the bracket, I think. So that they are like, ma'am, they highlight this point, ma'am, whatever you say, we are going to follow it. I think that's the beauty of family medicine. And it is also, it was very important in this case also. Kalpana, I would like to appreciate one more point in this case is your smoking de-addiction thing. That's how you complete as a role of family physician. In this case, de-addiction is important not only for the Graves ophthalmopathy and in Graves disease, but also a person as a whole. So may not be highlighted in by other specialty, but for a family medicine, it is very important.
And to give you the gold medal, I think one question that what are the other diseases associated with Graves' disease?
Other diseases associated with Graves.
Possible, likely to be associated with Graves' disease.
The HLA-DR gene is involved. I know this, but HLA-DR 3 and 4.
See, you're going on the right lines. So you could have rheumatoid arthritis. You could have type 1 diabetes.
Right.
You could have SLE. These are all, you could have Hashimoto's thyroiditis also associated.
Yes.
And I think just for the sake of completion, this gentleman should also be dewormed.
Okay.
So wonderful. We have finished well in time. Dr. Vishnu, you can very well share the same link with the OC of Vonka, sir. Thank you.
Thank you so much, sir.
Thank
On
you.
behalf of entire Rajasthan
Thank
team,
you
I would
very
like to
much.
thank you, sir,
Thank
for
you.
giving your precious time. Thank you so much.
Thank you and good luck.
Thank you.
Thank you.